Robert, that will complete the group 3-4 POSEIDON, and then we will have an, I hope, nice discussion also.
So the last presentation in this group of the POSEIDON subgroup criteria is the management of groups 3 and 4, POSEIDON subgroup patient. So just to start, no football this time. Patients of POSEIDON group 4 will benefit from recombinant LH supplement because they are older than 35 years old. They will have less pregnancy loss, higher live birth rate, or they will have more oocytes, or A and B are correct. So please vote. Okay, so 70% of you gave the right and correct answer. Patients are older than 35, so advanced maternal age. And they are, as Carlo showed you from the SPART study, will have less pregnancy loss and higher live birth rate if they receive LH. So some years ago, I visited China on a speaker tour, and in the hotel lobby, I saw a few women all dressed up in this red sweatshirt, and it was written POSEIDON on the back of them. So I talked to them and I asked, what are you? And they said, well, this is a tourist group. It's called POSEIDON. So I said, yes, and I am a member of the POSEIDON group, so the scientific group. So they found it very interesting. And when they heard that this is about infertility, immediately they asked, well, what are my chances and so on. So I picked two of them out of them, number 3 and number 4. And I discussed with them the possibilities. So I told him, if both of you will have a low number of oocytes, but you will have different probability to have a live birth rate with the number of the oocytes that you will have if you go in ART treatment. So they asked me, well, what can we do about it? I said, well, there is a whole list that we need to discuss, and then we can see what will be helpful for you and what not. Because the problem you will have in advanced maternal age will be the euploidity of your oocyte. So if you are young and have a low number of oocyte, it's different than if you are old and have a low number of oocyte. And here you can see the probability to have a an embryo which is euploid if you are in the different age. So the number of the oocytes and the number of the blastocysts that you will have will be crucial for your probability to become pregnant. And as we know from Seshonkara's large paper, the number is crucial, but even an increase in one oocyte, it has a meaning in every age group. And every oocyte, especially if you have a low number, will have an importance in achieving your goal of pregnancy and live birth. So what kind of treatment strategies can we have? So we shall look now at the pituitary suppression regimes, if there are any differences. stimulation approaches, adjuvant therapies, and probability of accumulation of oocytes or embryos. Now, concerning using GnRH antagonist or long agonist protocol, the Cochrane database showed that there is no difference at all concerning the outcome. And here they looked at ongoing pregnancy, and the Cochrane database accepts now an equivalence of ongoing pregnancy to live birth rate. So ongoing pregnancy are pregnancy over the 12 weeks. So the probability between pregnancies over 12 weeks and live birth is very minimal. It's just 1 or 2% that will not reach a live birth rate. So ongoing pregnancy is acceptable. So there is no difference in ongoing pregnancies if you use either the protocol. So both protocols are okay to use. What is about the dose of FSH for stimulation? And here you can see that using 300 compared to 150 will increase the probability to increase the number of the oocytes. But if you go above 300 units of FSH, there is no benefit at all. So you are not benefiting the patient by giving high doses. It's only very costly for the patient, but there is no benefit concerning the number of the oocytes. When you look at cancellation rate, again, using 300 compared to 150 will benefit the patient. Over the dose of 300, there is no benefit at all. So there is no reason to give more than 300 units of FSH. And concerning live birth rate, you see that there is no difference between the group. Nevertheless, a lot of studies were being very small, as Carlo explained to you, and also not all of them reported live birth rate. So it's a little bit difficult because the numbers are very small to say something about the live birth rate, but generally there was no difference. So what about a natural cycle? Will a natural cycle be helpful, or modified natural cycle? Well, here you can see analysis published some years ago, and for this subgroup of patients, the live birth rate is very low if you use the natural cycle. So it's actually not a good idea to suggest patient to use a natural cycle or modified natural cycle if they belong to group 3 or group 4. What about dual stimulation? Here we have some information that accumulating fertilized eggs or blastocysts in dual stimulation does benefit the patient to increase the probability to have in a shorter time a pregnancy and the live birth rate. And I will not go too much into detail now because Carlo Alvigi will have a presentation in the second part of our meeting today. So he will go a little bit more into details, but generally dual stimulation is a good idea to use in group 3 and group 4 of the Poseidon subgroups. What about androgens? Now, in order to understand why we think about androgens, is because androgens have two possibilities to interfere with the follicular development. First, in the initial recruitment of the follicle, which happens many months before you see the follicles on your ultrasound. And here you can see the mechanisms, how it works. And the other possibility, as Carlo explained to you, by the cyclic recruitment. So in the recruitment via androgen production in the T cells, that will affect the sensitivity of the granulosa cells to FSH for the follicular growth in the beginning of the follicular development. So this is the short term of enhancing the recruitment. And this is important because this will tell you something about the time that you might need to use androgens in order to see any effect at all. Now, the two most common androgens that have been used were either DHEA or testosterone by itself, but they are quite different. DHEA is quite a poor acting androgen compared to testosterone. So you see a difference in the bioactivity and the affinity to the receptor. But when you look into the interfollicular level of testosterone and androgen receptors, you see here, this is the follicular fluid testosterone. DHA does not increase the follicular testosterone level. And you need a high levels of testosterone in the follicle in order to have an effect. When you look at the testosterone increase in androgen receptor expression, again, you see a difference between testosterone and DHEA. Now, the latest meta-analysis on DHEA was published last year. And what you can see here, that there is actually no effect of DHEA on the number of the oocytes, on the metaphase 2 oocytes, on clinical pregnancy, or on live birth rate. So this is the latest meta-analysis that we have, quite a large one, looking at this. So generally, we can say that the scientific evidence is not there to suggest using DHEA and these subgroups. There is, of course, some advantage, and that's why it's very widely used in some areas in the world, because the cost is low. A patient can buy it, especially in the US, over the counter. You don't need a prescription. And even if you take it for many months, there are very low side effects because, of course, the effectiveness of the testosterone is not very potential. So generally, maybe we need some more trials, but I think we say it now for many years now, and we don't believe actually that it is helpful. So what about testosterone? So this was the latest meta-analysis on testosterone, because also before there have been some indication that using testosterone as a pre-treatment to the stimulation might increase the number of the oocyte and clinical pregnancy rate and live birth rate. But the numbers, as you can see overall here, are all very, very small. So it's difficult to have conclusions of such a small number. So because of that, it's needed to have a much larger study group. Also, the problem with all the studies that I have shown you before in the meta-analysis, the dose of the testosterone was different in every study. And the time that it was given was different, between a few weeks, a few months. So it was different to compare actually the results. So Nikos Politis, our friend, and also part of the POSEIDON group, started some years ago a very large trial. It's called the Transport trial. These are all Bologna criteria subgroups of patients. And they have been treated for a longer time, almost 3 months, with testosterone, 10 milligrams in patches. And after that, stimulation. It was a multi-center study. and it was powered to show a difference. Nikos Polis has finished now the study after many years because it was difficult to recruit so many patients. I think they had like 450 patients in each side of the group. And he will show here his results during the ESHRE, so you are welcome to watch his presentation. But I can tell you already the secret that there was no difference in the outcome between patient treated with testosterone, patient not treated with testosterone. So it doesn't seem to be helpful working. Another possibility to use androgens is on a different way by priming the T cells. And to use a LH to prime the T cells to produce in the T cells more androgens in order to be aromatized then and to have an effect on the granulosa cell FSH receptors. And this has been done some years ago. We repeated it in my center with exactly the same results, so it seems to work. So these are patients who are, according to Bologna criteria at that time, when recruited and had a very poor outcome in a normal long agonist protocol. And here you can see the previous cycles of this patient, so extremely poor outcome. So this patient have been treated in a long agonist protocol for 4 to 5 days with 150 units of recombinant LH before starting the stimulation. And there was an increase in one oocytes. In my centers, we did not see an increase in the oocyte, but the quality of the oocytes changed. So the probability to have a clinical pregnancy rate and the live birth rate was completely different. So this is one way one can help in very severe cases, for example, POSEIDON group 4, just to do a pre-treatment with LH in order to increase the endogenous testosterone production from the T cells. Another actor that was tested was growth hormone. And growth hormone has its own receptor on the granulosa cells and stimulation of IGF production. Growth hormone is actually a co-gonadotropin way of stimulating the ovary and has a regulatory effect on steroidogenesis, follicular development, oocyte maturation. So it's involved in many aspects of the follicular growth. So there was an idea that using growth hormone for stimulation or pre-treatment or treatment with the gonadotropins might increase the live birth rate. And indeed, one of the Chinese centers, which quite a large group, had looked at the live birth rate in all the 4 POSEIDON groups, and they found and published, this was published just recently, that they found a higher live birth rate in all the 4 POSEIDON groups. But this is only one publication. When we look at the latest meta-analysis, and this is the one published in Fertility and Sterility in 2020, they revealed that there was an increase in early pregnancy. There was increase in the number of the oocytes and metaphase 2 oocytes, but there was no difference in ongoing pregnancies and live birth rate using growth hormone as pre-treatment. Again, the same problem with growth hormone is that there are huge differences in the study concerning the amount of growth hormone that was used. If it was used every day, every second day, if it was used before starting stimulation. So there is a whole mixture, and there is no two studies that use the same protocol. So it's difficult to decide about the outcome because of that. And there is still a query, which is the best dose of growth hormone? What should be the duration of giving it? And of course, the cost effectiveness, because it's a very expensive drug to use. So if we ask the patient to pay for it, we need to make certain that there is some evidence of helpfulness. So again, we need more exact trials and not just trials in order to find the solution. And Carlo already told you about the SPART study to look at Bologna criteria aligned patient using recombinant LH compared to monotherapy with recombinant FSH. And again, as he showed in the result, there was no difference in the number of the oocytes, but post-hoc analysis showed that especially the more difficult patient, which will be probably group 4 of the POSEIDON subgroups, will have a lower pregnancy loss and a higher live birth rate by using recombinant LH in combination with recombinant FSH in the stimulation, which was explained by having a better quality of the oocytes at the end of the day. And this was the latest publication of patients over the age of 35 to look at the benefit of adding recombinant LH to recombinant FSH. So when you look generally about at the group of patients over 35, you will see no difference in the implantation rate and no difference in the pregnancy rate. And the number of oocytes and metaphase 2 oocyte was no difference as well. When you look at the subgroup of patients between 35 and 39, you will see a different outcome. You see that there is an implantation rate which is better, and the pregnancy rate is better. The same situation with the number of oocytes. So the number of oocytes is indifferent in the subgroups of patient 35, 39, or if you take all of them over 39. So the question is, how come well, we see a difference here when we look at the subgroup 35 to 39, and we see no difference when we look generally over 35. And the answer is very simple, because over the age of 40, as I showed you before, the aneuploidity rate is very high. And that aneuploidity rate will affect the outcome of the implantation and the pregnancy rate. So if you look at the whole group and you have a lot of patients over 40, it will dilute the outcome of the 35 to 39, where you can see better the benefit of using. So of course, the patients over 40, they always also benefit. But if you dilute the results, you don't see the benefit statistically. So this is the explanation to this curious outcome. So if you want to show it statistically, you look at the group 35 to 39, and then you see the benefit in advanced maternal age. Here, due to a aneuploidity rate, you will not see the effect statistically. But if you look at the live birth rate and the pregnancy loss, as we looked at the SPART study, you will see a benefit. So just to put things together now, group 3, POSEIDON, to remind you, are young patients with low ovarian reserve, poor ovarian reserve. So they can use either a long or a antagonist protocol or long agonist protocol. You might need to stimulate them up to 300 units of recombinant FSH. You might give them recombinant LH, but it's not really necessary. They benefit from dual stimulation because they will increase the number of the oocyte in a short time. This is actually the better subgroup of the patient because the euploidity of the oocyte is very good. So you will not need a very high number of oocyte in order to reach a euploid blastocyst for a pregnancy. So you can decide to do a fresh transfer or just accumulate. Group 4 is the more difficult one because of the high aneuploidity rate on top of the low number of the oocytes. So again, you can use a long agonist or antagonist protocol. You will try an antagonist protocol to synchronize with the pre-treatment, either with progesterones or estrogens, so you have more synchronized follicles. Here, you should add recombinant LH in order to benefit the patient with the quality of the oocyte. Fresh embryo transfer is, of course, always possible, but dual stimulation and accumulation and segmentation of the cycle is probably better in order to increase the number of the oocyte to have a higher aneuploidity rate. And again, one can use the calculator in order to decide how many oocyte you will need in this special patient sitting in front of you. So you can discuss with the patient how many cycles or how the strategy of the cycle should be in order to reach this number of oocytes that you are aiming for, especially with the low ovarian reserve. And this will help, of course, counseling and establishing treatments. So prediction, counseling, and individualization is important in these two subgroups of 3 and 4. They will benefit of 300 units of recombinant FSH and the advanced maternal age also of addition of recombinant LH. And there is still a big question mark concerning androgens and growth hormone additional therapy to these patients. So thank you very much.